Hi, today I'm going to be talking to you a little bit about chlorpromazine, the first antipsychotic drug. It was first synthesized by Paul Charpentier in a French laboratory for a pharmaceutical company. It was first released for antihistaminic drug uses and for nausea and allergies, but the first potential use in psychiatry was by Henry Labouré, a French surgeon and researcher. He observed that chlorpromazine introduced calmness without sedation and that it would be used in psychiatry. Now, I'm going to give you a quick example of how that works. Here we're inside the home of somebody who's experiencing a manic episode. We will now administer the chlorpromazine.
Oh, thank you.
Better?
Better.
So, what makes chlorpromazine such a unique and effective drug? Well, it is a substituted phenothiazine, which is an organochlorine compound and a tertiary amine that has a role as a phenothiazine antipsychotic drug, an antiemetic drug, and a dopaminergic antagonist. It can be easily recognized because of its three-ringed structure at the top shown here. The synthesis of chlorpromazine is a two-step reaction from 3-chlorodiphenylamine. In the first step, 3-chlorodiphenylamine is heated up with sulfur to yield 2-chlorophenothiazine. In the second step, 3-dimethylaminopropyl-chloride gets alkylated in alkalic medium with sodium amide as a catalyst to form chlorpromazine. Now, it is fundamental to study pharmacokinetics to understand what the body does to chlorpromazine. Let's start with metabolism. Chlorpromazine is extensively metabolized to numerous phase 1 and phase 2 metabolites. Some of those metabolites are active, like the case of N-oxide that converts back into parent drug. One of the main metabolic pathways includes the oxygenation reactions at carbon, sulfur, and nitrogen atoms. Another important metabolic pathway is the oxidative degradation of the side chain. Its metabolism occurs primarily during the gastrointestinal absorption and in the first pass through the liver. Now let's move on to an important pharmacokinetic parameter, which is bioavailability. It was reported that the fraction of chlorpromazine absorbed intact was less than 10%. The low bioavailability was concluded to be due to the extensive metabolism during the gastrointestinal absorption and in the first pass through the liver.
Chlorpromazine is used primarily to treat psychotic disorders such as schizophrenia and maniac depression. Chlorpromazine is a dopaminergic antagonist. It blocks postsynaptic dopamine D2 receptors in cortical and limbic areas of the brain involved in the control of emotional behavior, which prevents excess dopamine. The reduction of dopamine in patients who are affected by an excess secretion experience hallucinations and delusions. In the absence of chlorpromazine, the release of dopamine from presynaptic terminals activates postsynaptic dopamine receptors, which initiate a downstream signal transduction. In the presence of chlorpromazine, it binds to D2, preventing dopamine from binding to D2 and blocking downstream signal transduction cascades. This medication doubles as an anti-nauseating agent. It controls nausea and vomiting. The medication can be administered before surgery or after chemotherapy. The mechanism of action takes place in the GI tract, where the drug selectively binds to receptors in the vomiting center of the brainstem. It blocks signaling pathways where it inhibits stimulation of the GI tract, diaphragm, and abdominal muscles, therefore preventing the vomiting sensation.
After first noting that chlorpromazine had a calming effect, Henry Labouré persuaded Val-de-Grâce, a military hospital in Paris, to allow him to test the drug. The very first patient was Jacques LH, an agitated, psychotic 24-year-old male. Upon administering the drug intravenously, the effects were immediate, and Jacques was treated for 20 days before being allowed to return to normal life. Publication of this result spurred further trials in St. Anne's Hospital in March 1952 involving Jean Delay and Pierre Denneker, pictured to the right. These trials showed chlorpromazine's effectiveness, and by November 1952, chlorpromazine had quickly become a prescription drug. Within the span of 3 years, chlorpromazine became very popular, spreading all over the world for use. Looking specifically at one of the clinical trials for chlorpromazine in the US, a total of 3,014 patients ranging in age from 6 to 81 were treated. The results from this were that chlorpromazine was the most effective in treating agitated patients with mental disorders, but had little to no effect on those with depressive disorders, and in some cases even made symptoms worse. The major side effects noted were jaundice and leukopenia, a decrease in white blood cells, but both of these were present in less than 1% of patients and subsided after treatment was finished. Looking at the public opinion, chlorpromazine was the first antipsychotic drug, so it was met with hesitation, which may be due to psychotic disorders still not being fully understood. Additionally, it has been met with some backlash from scientific communities, as antipsychotics are now known for causing a host of side effects, most notably weight gain and movement disorders. Furthermore, chlorpromazine doesn't treat the cause of schizophrenia, but merely the symptoms, meaning a relapse is possible. While these side effects tend to go away after medication is stopped, they have been a topic of discussion in weighing the pros and cons of antipsychotics. Further research is being put into understanding psychotic disorders, as well as developing drugs that don't have these side effects. That is the end of our presentation. Thank you very much for listening.